Part 1. In this episode of The Road to Antalya, we have chosen 3 contestants from Asia to share their presentation with all of you. The first presentation is by Dr. Eo Wan Liang from Malaysia. He has chosen a case with common dilemma that we all face every day, therefore making his presentation relatable and engaging. Anterior implants are never easy. When do we decide to immediate versus delayed? How important is the buccal soft tissue contour, and how would this impact the clinical decision-making process? Dr. Liang takes us onto his journey 3 years back with this case presentation, and he also shares what he would have done differently if he were to do the case over again today. His genuine and honest approach to his presentation was well demonstrated. His documentations were detailed and spot on. Quality photos, x-rays, and follow-up records were well prepared. Things he could have improved? Not that many, but if I had to provide some feedback, maybe the use of illustrative diagram would have helped to support his reasonings and ideas so that it would have been easier for the audience to follow during the conversations. Additionally, I would have liked to see more reference to research articles to support his materials and methods. Overall, this was a solid 15-minute presentation. I wish Dr. Liang good luck on the next round. The title is Aesthetically Driven Staged Approach to Anterior Implant Therapy. Enjoy.
Yeah, Mr. Yoon. Good morning, Dr. Tan, the judge, and MINEC team, Miss Melody. Nice to see you all here today. Today I'm going to share the case that I thought is interesting to share. The patient is Mr. Yeo Kai Hock, 53 years old, with a periodontal problem of the 2-1 teeth with pus. So I decided to do this case with alveolar socket preservation and delayed implant with any reach 3.5 10 mm. This is because I want to prevent the uneven gingival height of the patient. If I'm going to restore the teeth only for function, I will go for immediate implants. But in implant dentistry, we are not only doing for function. We want aesthetic and longevity as well. So this is the intraoral photo of the case of the patient. You can see that the patient lost the gingival, keratinized gingival of so much because of the perio problem and the uneven gingival height of around 6 to 7 mm. And we have a very nice buccal crestal bone. If you are going to put the immediate implants here, there's no problem at all. We can do that. But the patient will have a very long crown with uneven gingival height. We don't want that to happen to the patients. So this is the final outcome that we have achieved after from that 2020 to 3 years from now. This is the 2 years, 2 months after the surgery was done. So I'll show you step by step how to come from the first with the uneven gingival height to this area. So from day one, I planned all my case using digital guided surgery. So when I plan to do immediate implants for the patients. I'm a bit herodontics. I want to bring back the gingival to the original position of the adjacent tooth. I planned, but because of the thin buccal plate with infection and an uneven gum line, I don't want to do some herodontics work. So I decided to do alveolar socket preservation and a delayed implant placement. So this is the second photo is the post-op of the alveolar socket preservation with the non-resorbable membrane of perma-mem. And actually, I use a lot of allograft for my patients, but for this patient, it's a bit special because I've explained the advantages and disadvantages of all the allograft, xenograft, and synthetic. But the patient refused to accept human bone and animal bone. So I decided to use osteon 2 collagen, that is a synthetic bone graft, with 30% of hydroxyapatite and 70% of beta TCP. I use a little of hydroxyapatite because the turnover of the HA is very less to turn over to the natural bone graft. So I use it there to preserve the bulk of the ridge. So I use osteon 2 collagen with 30% HA and 70% beta TCP. because the patient chose not to have the animal bone and human bone. Can you see the 3 months post-op of the alveolar socket preservation? Because of all the videos, can you see that? So after 3 months, I decided to do the implant placement, delayed implant placement. But for now, if I'm going to do this case again, I'm going to do autogenous dentin graft. That means when I extracted the tooth, I'll grind it down and put it in for the patients, using the patient's own tooth as a dentin graft. So now we go to the real situation. This is the first day of the patients coming to see me when he has all this perio problem and the buccally erupted of the 2-1. This is after the extraction, and you can see that the different gingival level between the adjacent tooth and the extracted tooth. And this is the post-op CT scan of the alveolar socket preservation with the osteon 2 collagen with the permanent non-resorpable membrane to build back the keratinized gingiva and attached gingiva that we have lost. I used the extracted tooth, I trim it and use the original crown to build a resin bonded bridge for aesthetic purposes, temporary bridge for the patient. And this is the holding suture of the to hold the permanent, the non-resorbable membrane in place so that it won't come out so easily, and we remove it after 6 weeks. So this is comparable photo of the patient. This is on the first day before the extraction. This is after post-op, immediately after the alveolar socket preservation. And this is after 3 months when we are ready for the implant placement. And I'm going to do again second augmentation for the patient because although we got this keratinized gingiva over here, we still lost some soft tissue and the bone graft to hold the soft tissue. And this is the July 2020 when we do the full guided surgery with any-rich implant. We try in the surgical guide that we have planned properly, and then we put in the implants in the cingulum position where we can use the screw retained crown without any cement remnants. This is the intraoral radiograph or the post-op after the implant placement. And during the implant placement, I do some palatal connective tissue graft using tunneling. And this is the osteon 2 collagen that the patient chose to have the synthetic bone graft, not the allograft or xenograft that I usually use. And this is the connective tissue graft that I use tunneling to put into the buccal concavity to get more soft tissue volume that we have, okay? And this is 1 day review after the surgery, after we put in the implants into the Mr. Yu. And we can see from this partially resolved oral 8 wound dressing to protect the wound dressing after we cement it with the resin bonded bridge to protect the socket. And 5 months later, we do re-entering for healing abutment. This is on the December 2020. And you can see that we have gained some keratinized gingiva and attached gingiva over here. And we'll try to mold it to get a better proper emergence profile. And during the re-entering stage, I try to use papilla sparing and roll flap technique to build more keratinized gingiva and build out the bulk of the soft tissue and emergence profile that we want. We spare the papilla incision. We don't want to incise over here. We want the papilla to fill up in so that we have less black triangle. And the ISQ level is 75, that is acceptable for loading. And this is after the surgery of the re-entering with the healing abutment in place. And I took a intraoral radiograph, periapical radiograph to check the connection of the healing abutment. You can see that the bone alveolar socket preservation is done pretty well with the interproximal bone height that is very good to support the papilla, so to reduce the black triangle we have later. This is 11 days of healing with the healing abutment. You can see that it's very well. There's less micromobility of the healing abutment, so that the healing will very well with any rich implant system. And after 1 month, I leave the healing abutment for 1 month for proper healing, because I'm I don't want to rush everything for the patient since the patient don't have the teeth for so long already with the temporary on. I want to make sure that it is 100% successful. So I wait for 1 month for the molding of the healing abutment. And you can see from the CT scan that the original native bone is over here. The peak of bone is over here. And the bone graft is going incorporated well into the buccal surface of the implant. And we have the gingival margin to be equal to the adjacent tooth. And this is 1 month photo of when I want to take the open tray impression technique. This is a close-up view with the healing abutment in place. And we have very thick tissue that can be seen over here. And it's very nice. And we have the vertical soft tissue height of 4 mm that is hugging the implants, that's protecting the bone graft that we put in the augmentation, and the implant for zero bone loss concept. We follow everything from zero bone loss concept. And this is the ISQ smart pack that I put in to check the ISQ level. And this is the pickup impression coping. I took x-rays to confirm. This is the ISQ level that we got 78 and 78. Since the last time when we put in the 1 month ago is 75 when we put in the healing abutment. So this is the fit of the impression coping that is very nice with the MegaGen implant system. So I sent the case to the lab and then I do a temporary PMMA molding to get the better emergence profile for my anterior aesthetic case. So this is the before molding, the photos is there. So after 6 weeks of a PMMA molding, you can see that the emergence profile, we push the papilla to the side to reduce the black triangle, and we get the very nice emergence profile of our future cement screw retained crown. So this is the final restoration that we got. I just want to show you all that the profile of the buccal surface of the customized abutment is concave, and the interproximal part is either flat or convex a bit to push the papilla so that we got the papilla. And the buccal surface is a bit convex so that the gingival margin will drop down and we get the buck to go into the customized abutment and hold it well. Our implant will be very successful. So this is the final OPG of the screw retained cement prosthesis that I put in, and the connection is very, very, very well. I always take OPG or PA for the front teeth to check whether the connection of the implants to my screw retained crown is perfect. So this is on the July, 4 months after the final restoration, and you can see that the orange peel appearance of the gingival margin, the keratinized gingiva and the attached gingiva, and the papilla is filling up fast because we know the concept of the customized abutment, the shape of the customized abutment that we want to do, that we can see that from the previously, the patient's gingival margin is higher up here. It's around 6 or 7 mm higher up without any keratinized gingiva. So you can see that the emergence profile after the molding of the PMMA is very nice, and we got all this emergence profile and the high vertical soft tissue that is protecting the implants right here. This is the photo of the implants after we cemented in the screw in the permanent restoration. And 2 years, 2 months review. After September 2022, you can see that the implants augurs well with the papilla filling in, less black space, although we have some shrinkage of the bone augmentation and the soft tissue augmentation. That is why delayed implant placement is less predictable compared to if we are going to do immediate implants. If you do immediate implants with customized healing abutment, we'll get better at our emergence profile of our future crown if we can do immediate implant placement. So this is close-up view. You can see that the attached gingiva and keratinized gingiva with the stipple appearance is very nice. And this is the CBCT, when I review after 2 years of the patients, you can see that the bone has already formed very well with zero bone loss concept, and the synthetic bone, although it's a synthetic bone, it binds well with the original native bone of Mr. Yo. It's very nice. And final comparison before and after the treatment. So at first we lost a lot of keratinized gingiva. There's no keratinized gingiva in effect, infection, imperial problem, and bone loss, and thin buccal bone, and it's all buccally erupted. The tooth is mobile, mobility grade 2 to 3, and we've passed. So I decided not to do immediate implants. I don't want to do any heliodontics, so I can use the patient's own teeth to put the resin bonded bridge back for the patient for aesthetic purpose. So the patient still have. So this is the post-op after the alveolar socket preservation with the non-resorbable membrane to build back the original gum level for the patients. And I'm using the patient's own tooth for the resin bonded bridge. So this is before. On April 2020, we have this problem. Loss of the, and we gain of the keratinized gingiva of so much, around 6 to 7 mm of keratinized gingiva after we use the alveolar socket preservation and 3 months delayed implant placement for the patient. Thank you so much for your attention. Thank you so much, Dr. Tan, everyone from MINEC, Mr. Yun, Miss Melody. Thank you so much. I think I am only using 14 minutes.
Yeah, 14
It's
minutes.
nice. Thank you so much.
Dear esteemed colleagues, I'm here to introduce you a dentist from Hong Kong, Dr. Chao Ji, with a very challenging case in the reconstruction of anterior aesthetic region, and the final outcome made the trumpet player patient very satisfied. Dr. Chao's topic is clinical and histological result of allogenic cellular bone graft with titanium reinforced non-resortable membrane for rich augmentation. I recommend this case to share with everyone is because as an implantologist, it is a typical problem we all face, especially for the young dentist. Reconstruction of upper anterior failure implant due to infection with a huge buccal site alveolar rich bone defect and soft tissue deficiency like papilla loss, lack of keratinized tissue, and vestibular depth require a complete treatment planning, mature surgical skill, and sufficient academic background. So Dr. Chow's treatment procedure step by step to do soft tissue graft, vertical and horizontal bone augmentation with the correct manner of biomaterials and primary tension-free closure, which respect to the biological factor to rebuild an ideal peri-implant phenotype. The implant placement with CBCT guide surgery stand and customized screw retain crown fabrication was done accordingly. The only comment I suggest is to persuade the patient to do periosteoplastic flap surgery for papilla gain. So let's welcome Dr. Chow's presentation.
Dear colleagues, my name is Chao Ji, and I'm very excited to share with you my case report about the clinical and histological results of allogenic cellular bone graft with titanium reinforced non-resorbable membrane for rich augmentation. My patient was a 59 years old Caucasian male when I first met him. He is a trumpet player for our local American football team, Baltimore Ravens. He wanted to have dental implants to replace his missing upper front teeth. Medical history-wise, he has hypertension with medication. He had been wearing a 3-unit dental bridge from 1-2 to 2-1 for over 22 years until the abutment tooth 2-1 had root fracture back in 2014. A local dentist extracted tooth 2-1 and immediately placed implants at sides 1-1 and 2-1. However, 3 months later, both implants were removed due to infection. Subsequently, tooth 1-2 was also removed as it was suspected to be the source of infection. Patient had then been wearing a removable partial denture, which he didn't like at all. He is a trumpet player, and the removal appliance really interferes with his performance. Extraorally, he has square face with strong mesenteric muscles. Although he doesn't show a big smile, we should always take extra precautions when we're delivering implant treatment in aesthetic zone. Intraorally, there is a significant horizontal and vertical ridge deficiency both clinically and radiographically, where implants could not be placed directly. Other diagnoses include localized plaque-induced gingivitis, partial edentulosum, the tooth wear due to parafunctional habit, gingival recession around tooth 2, as well as the lack of vestibular depth and keratinized gingiva at the edentulous ridge area. The comprehensive treatment plan is as follows: oral hygiene instruction and prophylaxis, and the delivery of mandibular night guard. Regarding the implant therapy at the edentulous ridge area, we will start with free gingival graft. Then hard tissue augmentation with the principle of guided regeneration or guided bone regeneration will be conducted with a healing period of around 9 months. After that, implant placement will be conducted along with the possibility of additional hard and soft tissue augmentation. Essex retainer will be used as the provisional restoration during the healing period. Then provisional crowns will be used for gingival molding, and then final crowns. A 6 months regular checkup and implant maintenance will be followed. Based on Urban's clinical study about the surgical management of significant maxillary anterior vertical ridge defects, the current situation has shallow vestibule and scarred periosteum from multiple previous surgeries. Therefore, it is a very challenging situation and meticulous flap management is needed. Before I picked up the scalpel, I picked up the wax knife to wax up the ideal tooth positions, gingival margins, and papillary height. As we know from Tarnow's classic study, the inter-implant papillary height can be 3 to 4 millimeters from the alveolar bone crest to the contact points. Therefore, the wax up serves as the guideline not only for the buccal-lingual dimension of the horizontal ridge augmentation, but also as the guideline of the alveolar bone height to which the vertical ridge augmentation should ideally achieve. And this is the modified Essex retainer, which replaces the missing anterior teeth and also protects the donor site after the gingival graft. So we started the surgical treatment with free gingival graft with the aim to increase the amount of keratinized gingiva and vestibular depth, which lies down a solid foundation of the flap management of guided bone regeneration. The healing was uneventful, and we allowed for 3 months for the soft tissue healing. Then it's time for the guided bone regeneration. After flap reflection, iodine was used to clean the site due to previous infection and implant failure. Intramural penetration was performed to increase the angiogenesis. Periosteal sharp dissection was performed to increase the buccal flap mobility. Then the non-resorbable titanium reinforced DPTFE membrane was secured with 4 membrane tacks to achieve the best clot stability. The bone graft material chosen was stem cell containing cortical allograft. Special processing procedures of this bone graft made it possible to keep the osteogenic stem cells in the graft. This was mixed with freeze-dried cortical allograft in 1:1 ratio. Tension-free primary closure was achieved, and the Essex retainer was used during the healing period. 8 months later, the combined CT scan shows significant increase in volume and density of the alveolar ridge at site 1-1 and 2-1. The wax-up was then scanned and merged with the cone beam CT scan, and a tooth-borne surgical guide was printed. 9 months after the GBR surgery, the re-entry shows intact membrane after flap reflection. The regenerated bone density was excellent, as you can see in the video, and the horizontal and vertical dimension was more than enough for implant placement. A fully guided implant osteotomy was performed. Bone cores were harvested at sites 1-2 and 1-1 for histological analysis. Site 1-2 is the natural bone healing site, and the vital bone percentage was high as expected. At site 1-1, which GBR was performed with osteogenic allograft bone material, the vital bone was as high as 49.7%. This is significantly higher than the vital bone percentage grafted with a mixture of bioxenograft and autogenous bone chips. Then implants were placed through the guide to ensure accurate placement. And a cellular dermal matrix was placed at the ridge crest to further increase the crestal soft tissue thickness, not only to prevent the peri-implant bone resorption, but also to increase the papillary height. And again, primary free tension closure was achieved and Essex retainer was adjusted. 2 months later, stage 2 implant surgery was done with papillary preservation technique. And fixture level implant impression was made, and the gingivoplasty was also performed to remove the buccal-gingival rugae from the previous palatal graft. 1 week after the stage 2 surgery, screw-retained PMMA provisional single crowns were inserted for soft tissue molding. And the patient already got so excited as he claimed these provisional crowns were the best Christmas gift ever. His daughter kissed him for the very first time in the past 3 years. And 3 months after the delivery of the provisional crowns, customized impression copings were fabricated for the final impression. And final screw-retained porcelain-fused to metal single crowns were delivered. And the X-ray shows good bone level, and the patient is very happy and satisfied with the outcome. And then the mandibular night guard was also adjusted. An 18-month follow-up, after the delivery of final crowns were conducted, and as you can see, the peri-implant soft tissue condition was healthy, and the bone level was stable as well. I would like to end my presentation with this very happy patient. Thank you very much for your attention, and these are my reference. Thank you again.
There's a saying, you can never be too rich, never look too young, and never have too much bone. In the next presentation, Dr. Andrew Byung-Hoon Lee from South Korea talks about bone grafting, the topic that we can all relate to. I really enjoyed the way he organized and structured this presentation. An overview on the principle of bone grafting, relevant research papers and materials and methods were clearly presented. He talks about the use of Santal abutments in combination of sticky bone, and how this combination can overcome some of the clinical challenges by simplifying overall surgical approach. I enjoyed the simplicity and the clarity of his presentation. Documentation was high quality, x-rays were well organized, and more importantly, the introduction, the main body, and the conclusions were clearly stated, and the time management was very good. Only thing I would have liked to see is maybe perhaps better introductory slide to who he is and a little bit of his background before he started the main body would have been good. A bit more research support and article references and a better storytelling to keep the audiences engaging. Otherwise, this was a wonderfully documented, a very interesting information-packed 15 minutes. The title is Guided Bone Regeneration with Santal abutment and Sticky Bone. Enjoy.
everyone. My name is Dr. Andrew Lee, and I want to thank you for giving me this opportunity to participate in this amazing event. Today, I'll be presenting on GBR, guided bone regeneration, using a special abutment called Santa with sticky bone for the best outcome. Here are the background information. Let's start with the fundamentals of a successful GBR. GBR is being performed everywhere with very predictable outcomes these days. To exaggerate a little bit, it has become almost like a daily routine when placing implants and providing implant dentistry. Dr. Homley Wang from University of Michigan Perio Department presented the 4 pillars of successful GBR and called it the PASS principles. P for primary closure, A for angiogenesis, S for space creation and maintenance, and another S for stability of wound and implant. Next, we need to look at the long-term result of a lateral ridge augmentation, which has been well documented. This 2018 systemic review article showed that regardless of the graft material used, different degree of graft resorption was inevitable. Therefore, it's safe to say that overcorrection of a horizontal defect should always be performed to compensate. Next, let's look into GBR from different viewpoints. I'm going to go through 3 questions. First question, should we perform simultaneous GBR or staged GBR? Simultaneous means GBR with implant placement, and staged refers to 2 separate surgeries, GBR, followed by implant placement in the future. Then the second question is, how are the GBR outcomes when particulate graft materials with collagen membrane were used over implants placed in native bone? Lastly, third question is any one specific GBR technique better than other techniques? So GBR versus distraction osteogenesis were compared, in other words, ridge splits. To answer all 3 questions above, implant survival rates were all comparable and similar. Therefore, our takeaway from these questions should be that we should be performing simultaneous approach GBR whenever possible, using different graft materials since they show similar implant success rates, along with added benefits such as lower morbidity from less number of surgeries and also increased patient comfort from overall shortened treatment duration. This is where Santa abutment and sticky bone comes into play. Unlike more conventional and technique-sensitive methods such as block bone harvesting and grafting, utilization of titanium mesh membranes, and etc., Santa with sticky bone allow us to predictably overcome the challenges of GBR and allow us to well execute the PASS principles from the previous slide. So again, Santa with sticky bone allow space creation and maintenance with minimal bone loss. It helps with graft stabilization, and it helps with upregulating angiogenesis, and it helps with overcorrection of graft material. And of course, it allows simultaneous approach of GBR. As you can see from the picture here, Santa has to be used with an implant. So therefore, we have to provide a simultaneous approach. Overall, we can use Santa as a simple solution in making difficult GBR cases easier and more predictable. Now let's look at my case report to evaluate the efficacy of GBR when Santa and sticky bone were used. So we have a 52-year-old Asian female patient with non-contributory medical history. Most of her dental works were completed more than 10 years ago. So when you look at this panel, her upper anterior stands out, 4-unit bridge from 13 to 21 with not the best abutment teeth since because of the questionable endo work. Also, very questionable endo work on numbers 22 and 23. Since these teeth were asymptomatic, we decided to monitor these for the time being. 1 year later, she comes in with a catastrophic failure to her 4-unit anterior bridge, and number 13 was deemed non-restorable at this point. After going through different treatment plan options, the patient wanted to go through the following: extraction of number 13 and implant placements at number 13 and number 11 with simultaneous GBR. Also, we'll fabricate a temporary crown on number 21 during implant healing period, and endo retreatments were recommended on numbers 21, 22, 23. After osseointegration of implants on 11 and 13 site, we're going to provide brand new restorations from number 13 all the way to number 23, all at the same time. So let's go into surgery. Upon opening of the surgical area, please note the significant size bony defect in number 11 area leading up to the anterior nasal spine area, and that bony defect communicated with the incisive canal. Already very thin facial plate of number 13 completely broke and came off during the extraction of number 13. After thorough debridement of the area using piezo surgery, 2 immediate implants were placed with excellent insertion torque of over 50 plus Newton centimeters. For better insertion torque, osteodensification protocol was utilized using densa burrs. Then 305 centa abutments were connected. That means the top part diameter is 5 millimeters and the cuff height of 3 millimeters. Then about 2 cc's or more of sticky bone made of 50-50 allograft and xenograft mixture was placed. I usually do not utilize resorbable collagen membranes too often, but due to the size of the graft in this case, I had decided to place 2, not 1, 2 pieces of collagen membranes. The first membrane was placed under the palatal flap prior to the graft placement. The second layer of collagen membrane was placed over the first one at the facial or at the buccal, going from one side to the other, mesial to distal, distal to mesial. One thing I want to point out here is that I did not need any fancy techniques, no use of periosteal stabilization sutures, membrane tacks, or fixation screws, etc. to hold the graft in place. Sticky bone was moldable and stable enough to hold its shape after I placed it. So I only needed to have a few horizontal matrix sutures for closure, and that was enough. Multiple layers of CGF membranes or PRF membranes were used to cover collagen membranes to upregulate and accelerate the soft tissue healing. Good primary closure was achieved, like I said, with some horizontal matrix sutures. This is healing after 1 month. The temporary crown from 21 is shown in this photo. Patient was using an Essex retainer during her healing for the 11 to 13 area. At 4 months, I re-entered for uncovery, and wow, look at the amount of bone regeneration, both in horizontal and vertical dimensions. And this is the final restoration after some gum grooming work. and of course the endo retreatments on 21 through 23. Another view, implant angulations were spot on, allowing me to have SCRP type restoration for possible retrieval in the future if needed. And this is a final smile. This is a final panel after the restoration delivery. Some images to recap here. This is a 3D view of before surgery. The defect that communicated through the incisive canal was pretty impressive. Another view, and this is at 4 months healing. You can really appreciate the amount of bone regenerated here. Another view. This is after restoration delivery. Note the newly generated bone volume that's maintaining. Another view. And let's look at some cross-sectional images. This is for number 11 implant site. The red line indicates the dimensional changes at the facial plate. And I was able to achieve this good multi-dimensional GBR with the use of sticky bone and Santa. And this is number 13 area. Red line indicates again the dimensional changes at the facial plate. And this is the 9 months post-op cross-sectional images. You can see the bone maintaining its volume. So the use of Santa abutments and sticky bone allowed us to follow the 4 principles by Dr. Homlin Wang and more. Actually, we were able to overcorrect and overbuild the ridge to compensate the inevitable future resorption. Santa prevented the collapsing of the crestal soft tissue after surgery, therefore achieving the goal of space creation and maintenance. In conclusion, for more predictable outcomes and for more patient-centered treatment with less known complications, the use of Santa abutments should be strongly considered when tackling such difficult GBR procedures. Thank you. These are my references. Okay, that's all I have for today. Thank you.
Those who are joining me live, we appreciate your support. And those who cannot, these presentations are 15 minutes long and will be available on our website, globalmegamind.com. Unlock your potential, test your mind. We are Megamind.